Hello, my name is Dr. Mansoor Moidani. I'm a family physician, family medicine trained physician, and I will be speaking to you today about my case for implementing physical activity as the fifth vital sign. Thank you so much today for tuning in and giving me an audience. A little bit about myself before I get started. I am family medicine trained, and I started my journey treating patients with lifestyle and obesity medicines after my own. I've lost 70 pounds myself during residency, and I learned from personal trainers and personal experience about the science behind weight loss. I started a project while I was in residency, while I was hoping to help my own patients, and I've realized this is a great way to treat many of our chronic diseases that we face every day. So I started practicing lifestyle and obesity medicine. I still practice as a hospitalist as well, and I like to start clinics focusing on lifestyle and obesity medicine in the future. So I encountered this quote while I was on the internet, stating that a man's health can be judged by which he takes two at a time, pills or stairs. Now, we see the quotes like this all the time, highlighting the need and benefits of exercise in our daily lives. And there's so many of these quotes, and the research is out there as well. There's new research coming out every month, every week, about the benefits of exercise on our all treating chronic diseases and improving our lives. But we haven't been able to fully mobilize all this research into practical methods of treating our population, our community, like on a scale. We still struggle with preventative care and utilizing this. So, today I'd like to communicate a vision for a better way of healthcare. But I also want to say this is a reminder, because there's so many of us in this field already contributing to this vision, and we've had so much research and so much progress already that a lot of things that we talk about is things that we need to emphasize. And hopefully I'm able to provide a little insight alongside the many insights and pushes forward that we all do together. And hopefully this is how, for the patients who are listening, you get a little spiel of how I talk to my own patients. So modern medicine is also often described as reactionary. We have a fee-for-service model that's when someone comes through on our door, we're often treating some of these diseases, whether it's diabetes, hypertension, even heart failure. We might start patient on diuresis, getting flu out of their body the same day they come to see us. And it's often these band-aids that we put on. And the modern doctor is sometimes getting a little bit wary of it. That might be contributing to our burnout, because many doctors do not feel they're adequately addressing the chronic diseases. We feel like we're constantly changing. We feel like we don't have enough resources. There's not enough investment in preventative care. There's not enough reimbursement. There's not enough manpower. The list goes on. So we are in this reactionary medicine system. But, there's a good argument to be made that in America, this is the best service you can get. And it's also the heftiest fee that you have to pay for that service. So the historical model has kind of highlighted preventative care. Like Benjamin Franklin famously said, an ounce of prevention is worth a pound of cure. Now, how have we been doing in that regards? I'd say we've been, as well as the doctor on the bottom of the next figure, trying to mop up all the chronic diseases and ailments that we as a society have succumbed to. And we're doing a poor job of it. Obesity is at an all-time high, and hypertension and diabetes, everything across the board is increasing, even though we've had many benefits in the medications and improvements in that regard. So how do we address this? So how I feel about this is that we have to be aggressive. I believe that we need a strong forward approach. Every time you step into your PCP office, it should be to get you one step closer to your optimal health and your body composition. And we need to highlight the barriers. Why aren't we getting there with you, with each patient? Have a plan in place to address those barriers. Instead of controlling disease and putting Band-Aids on it when they come into our office, we should be emphasizing prevention and chasing down health. How do we do this though? We set goals. We set goals based on sex, age, the ability of each patient, and we set cardiovascular fitness goals. We set VO2 max goals. We set body composition goals. We set all these goals to create an ideal profile for our patients, and then also includes macronutrient goals and deprescribing goals. If a patient comes to us and they're already on 2-3 medications for hypertension or diabetes, we should set goals to deprescribe. Once we get you to this activity level, this performance level, we expect to see some level of improvement in these chronic diseases, and we want to take you off of 2 out of 3 of those blood pressure medications. So we have to set those goals. But how do we achieve our goals? We do it through tracking, and tracking physical activity as the 5th vital sign. That's the point that I would like to drive point today. And I'd also like to, when we say tracking, I want us to think tracking to achieve our goals and our end results, because they almost become synonymous when we do it correctly. So to begin with, let's get a little philosophical. You guys are familiar with the law of attraction. And, I've learned that there's similar things in Ayurvedic medicine, like attracts like. So law of attraction states it's as if you're putting out positive energy with a clear vision, and you're progressively moving towards that. You expect a positive result in return. The energy we put out is similar to the energy we get back. And I want to take that a step further and use that in our everyday clinical activities with the law of tracking. With what you track is what you get. You track more steps, you get more of it. You get more fat loss. You start tracking your workouts. You get steady workouts in a structured fashion. Patients realize how much they're working out, how much time, how much intensity, how much weight on the bar, and they slowly start increasing the weight on the bar as the muscle stimulated. They get more muscle. You start tracking how much vegetables you're eating, how much fibrous foods. You're suddenly eating more of it when you realize how much you're not eating or how much you should be, and you get more health and you get longevity. And this has been proven in many studies. I want to get into tracking vital signs, but let's take a quick minute to go over vital signs. So we use them across the board in clinical settings. They can detect medical problems very quickly. They give a quick profile of our patient's health. They can also be measured everywhere. But the 4 main ones are heart rate, blood pressure, respiratory, and temperature. A close fifth that we commonly use is the oxygenation in many clinical settings. But most vitals are clinic setting specific. And we do track some activities with functional status and gait speed. So we've tracked other vitals before, as much as we track the other ones. And one infamous vital is pain. There's a big movement in America to track and address pain as the 5th vital sign. But my assessment about there's so much to talk about here, but my philosophical assessment here is that pain is often an end disease state, and it can often be subjective. So I want to go into this in a little bit more, but it's often an end disease state of trauma, cancer, inflammation, infection, arthritis. These are often the end result of a lot of these downstream. And now I want to talk about something that there's more to it than how I present, but I still believe there's a case to be made, is that, again, what you track is what you get. There's many factors that went into the opioid crisis in America, but one could say that our emphasis on addressing pain has had a significant impact on the opioid crisis. And one other thing I'd like to highlight here is something similar to how we're going to address physical activity as well, is how pain is often subjective, and the lack of education of many of the clinicians who are addressing in pain how to address it appropriately. We did not have the education needed to address a subjective finding that we were facing. So education is important. So why not track physical activity? So I want to focus on treating health. So physical activity is one of the beginning stages of our health. And I want to focus on a healthcare system, not a sick care system. And if vital signs can indicate the status of health, why can't activity be used as a vital sign for a barometer for it, with poor activity being low health and appropriate activity highlighting good health? I think it can be used that way, and it should be used that way. But what is physical activity? Really, it's any type of bodily movement that you contract your muscles and you expend energy doing so. It's me picking up my mug. That's physical activity. But we commonly interchange that with exercise, which is actually a subset of physical activity. And exercise is how we move to improve physical fitness, like when we specifically go work out. Now, things like walking in this picture could be physical activity. That's exercise if we're trying to improve physical fitness. But if we're just moving, that's just simply physical activity, which is still beneficial. But why track them? Now, why are we tracking it? Tracking is a way for us to collect data. And then when we view data, when we go over it, we're able to get insights from it. And that's not only for us, for our patients. One thing I commonly do on initial assessment is actually have my patients take out their iPhone. And if they have it, majority of us have iPhones these days, you can quickly go on there in the health app, and they don't know this, but the iPhone has been tracking their steps since they got it. So when they look at it, you track your steps. When they look at how many steps I'm getting, it's often under 2,000. And when they see that I'm only getting 2,000 steps a day, granted it is when they're only holding their iPhones, but when they realize they're only getting that, they find that very impressive. It's very impressive. And that allows them to have insight to realize where they're at, where they need to be, and be accountable to themselves and to us when we set plans. And I'm able to do that. I'm able to sit with them. I'm able to do even cognitive behavioral therapy, going over reasons why they can't and what are barriers. And we ultimately make a shared decision making that they're accountable for. And I love how this helps me rewire their brain. And I love how when they track, when they write down how many steps they have, they're able to journal and use the journaling power for self-transformation. So why do we track it? We need more of it. This graph right here just simply shows that, only about 20% or, 20% of the average American, 18 or older, meet the aerobic and muscle strengthening guidelines that the US has set out. And this is currently like almost a global pandemic. This is not news. So we need to be proactive. We need to address this. And to address it, we track it, we set goals, and we try to achieve them. Cardiovascular respiratory fitness is noticed to be like the #1 cause of mortality. It can be attributed to all the other diseases. And this is reversible. This is modifiable. It's not a surprise. We see these graphs all the time where the darker colors represent things like obesity, heart disease. This represents inactivity. About half of the states shows that like inactivity is about 20 to 25% prevalent. And in some of the states, in a good handful of them, it's greater than 30%. And this is costing the US about $117 billion in annual healthcare costs. And 1 in 10 premature deaths. There's one particular factoid I'd like to highlight right now and come back to, is that just 10 minutes of activity per day could save about 110,000 lives per year. That's impressive. And I want to revisit that. Why track it again? To treat and prevent disease. So across the board, heart disease, blood pressure, type 2 diabetes, cancer, infection, obesity, dementia, deprescribing, activity, increasing activity could help all of these. And I want to ask you a question. I really want you to answer it. The answer may be obvious, but if you had a choice between raising someone's insulin units, Lantus units, for their diabetes, or increasing their level of physical activity, what would you choose? The answer might be obvious. It might be just to increase their physical activity. I hope it's obvious, but that's what we should be doing, and we can do it. And I'd like for you to hear me out. So right now, average physician is noted to be only talking to 60% of their patients, or 60% of physicians are only talking to, their patients about activity. We should increase that. So the physical activity guidelines for America notes that about half of all Americans have one or more preventable chronic disease. And 7 out of 10 of these diseases are influenced by physical activity. But 80% are not meeting the key guidelines. See how there's so much lopsided, so much room for potential, but there's so many gaps in how we're addressing it. So what are the goals? The goal is, this is a neat graph you've probably heard a lot. The ideal amount of physical activity to get is 150 to 300 minutes of moderate to physical activity. And where you can see this graph plateau is around 150 to 300 minutes. Once you get above 150, the returns to reduce your mortality becomes lower. So that's why we come up with this number, and it has been very effective so far, but we are not meeting it. And I'd like to tell you how we could. So we also track physical activity to optimize health. A lot of this is not new news. We all know this, but new news, new studies coming out enforcing it. But oftentimes it's genetic dependent though, and also depending on the type and the intensity that you do the physical activity, it does help how much you optimize it. But the benefits are always there, whether it's acute changes or chronic changes, if your brain, sleep, quality of life, metabolism, immune health, bone densities. For our older patient, preventing falls and injuries and fractures that ultimately increase their morbidity and mortality, it helps across the board. Not only are you preventing and treating diseases, you're really creating superhumans by taking this up a notch. And tracking physical activity is really the next step for physicians to step out of their clinic walls and step out in the community. During the COVID pandemic, we've seen a lot of increased sedentary activities, and secondary to that, a lot more chronic disease develop. If we were tracking physical activity, just like we have options to do remote patient monitoring with blood pressure, heart rate, and other vitals, we could see that the beginning stages of causing increased blood pressure and diabetes could be seen in the decreased level of activity that these patients were doing during this time. Then we could have noticed that going into the red, and we could have created a plan from our clinic to their home about how they need to increase their activities. And in order to do that, we truly need a collaborative model. We have the telemedicine on our end, but we need to connect with coaches, gym, fitness trainers in our community. This allows us the ability to do so. Now, me personally, I do obesity and lifestyle medicine. In obesity medicine, there's what's called the set point theory. This set point theory has a host of different things, everything that affects where our weight ultimately lies. And one of the big parts of it is physical activity. It's part of our behavior. And when I can move the needle of their physical activity, increase it by 20%, I see a shift in that set point. And that's enough to buy them an extra 3 years of life, enough to take them off that diabetes medication or blood pressure medication, live a happier and healthier life. So it really allows me to empower my patients and change their lives. Something that's making huge waves are anti-obesity medications is the new GLP-1s. And we've seen tremendous benefits of 15% weight loss amongst 86% of participants. But a criticism has been that they've lost a lot of lean body mass. But overall, I have to say their percent of skeletal muscle mass is higher than their fat, and their overall body composition does improve. But I still focus on preventing muscle loss. And the way I do that is I really have to track their activity with what they're lifting, how they're lifting, the core workouts they're doing, how many steps they're getting, and emphasize that during their weight loss journey. Now, I want you to feel empowered about how you use physical activity. You guys, many of us have probably played video games, and at some point in different types of video games, you're allowed to create your own player. Whether it's probably, I don't know if you can do it in Mario Kart, but in basketball games, fighting games, you can change the stats, the shooting potential, the playmaking, defense, strength, jumping ability, speed, strength. There's always a mix of things you can do. Okay, you following? So I'd like for you to think of it that way for your patient's health. These dials right here, heart rate, blood pressure, respiratory rate, temperature, physical activity. The only way you can change those first 4 dials is often with medication or some sort of physical intervention. You can use a beta blocker to suppress the heart rate. You can also do that for blood pressure. You can give a patient a breathing treatment for their respiratory rate. You can give a patient Tylenol or a bear hugger for their temperature. But for physical activity, you can actually sit there right in front of your patient, have a human connection, and if you're able to bring that up, you're able to adjust all the other vitals. There's no other tool in our toolbox that is more effective than changing our patients' lives. So I want you to think about raising up that dial instead of increasing the dosage of lisinopril. Or do that, increase the dosage to control their blood pressure medication. But I want us to think about that dial of physical activity first before we turn to medication to control it or de-prescribing it, because ultimately we do want to keep our patients safe. So challenges. This is often, everything has its challenges. The biggest challenges are structural, whether it's neuropathy, arthritis. About less than half of adults who have like a mobility issue reports like actively engaging in physical activity. A particular patient that I had with Charcot's foot that I still remember was limited to about 3,000 steps. So I had to max out their steps that podiatry would allow. Then I had to focus on dietary to control their health. Anxiety and mental health are huge. Some patients have struggled so much that they do not want to talk about it. I still remember a patient that I was on a video visit with, and he didn't want to turn on the video because he was too anxious. And it was very challenging, but there's challenges in talking about it. Patients who've tried everything are very hesitant to talk about activity because it brings a lot of insecurities. If we're really going to push physical activity, we'll also have to monitor them a little closer. If they're on blood pressure medication, if they're on diabetic medication, they may become hypotensive or hypoglycemic as we improve it. This is also a double-edged sword because it allows us the ability to de-prescribe. So I want to talk about my work briefly. So I started a weight loss program during residency, and I recruited as many patients as I could. Unfortunately, the residency limitations, I only was able to do 19 with a limited maximum of 1.5 days per week. And of these, for the criteria I set out was they had to follow with me at least 4 times. 12 met this criteria. I tracked their daily weight. I tracked their daily steps and servings of vegetables. And what I found was that patients were getting less than 2,000 steps per day, and on average, less than 1 serving of vegetable. So how did I track this? I had a simple Excel sheet, and I tracked their daily steps, more daily weight if I felt they were mentally appropriate and could handle tracking that, number of servings of vegetables, and I had them follow up with me every month. Currently, I also track the grams of protein. So what did I see? I saw tremendous results. So these 3 cases I'm going to go over are a reflection of a lot of the other ones. One patient lost 74 pounds, reduced their A1C from 9.9 to 7.2, took them off of blood pressure, microalbuminuria resolved, increased self-esteem, improved joint pain, and completely changed her dietary activities. A second patient who only lost 4 pounds was able to increase their steps to 7 to 10,000, was initially on losartan 50, hydrochlorothiazide 12.5, and amlodipine 5 milligrams. Over the course of 6 months, with increasing their steps and improving their vegetable intake to 4 servings a day, I was able to take them off all their blood pressure medications. And that also shows a benefit of physical activity, that even if you don't decrease the weight, there's a great benefit there. Here's a patient that lost 10 pounds. This is the patient with the Charcot's foot. Increases the serving of vegetable from 1 to 4 to 5 servings a day because I was limited on activity. And they were on lisinopril 40 and hydrochlorothiazide 25 milligrams. Over the course of 10 months, I was able to deprescribe all the medication with a 10-pound weight loss. So my conclusions were that diet and activity were integral to obesity counseling in positive changes. And with doing these, I was able to improve their chronic diseases. But, I think I've highlighted how this could be done. But, and sometimes when we talk about these topics, we're doing it in our individual spheres, but we have to recognize there's many physicians, many healthcare professionals already pushing a lot of these initiatives that we should also learn from. And I've learned that there is a global initiative now that the Exercise in Medicine, which is started by the American Medical Association, the American College of Sports Medicine, has already a great template that we can follow. So they use a validated measurement called the PAS, Physical Activity Vital Sign. They're able to track how many days per week patients engage in moderate to vigorous physical activity and how many minutes they're doing it for. And they do a great job of explaining what vigorous and moderate and vigorous physical activity is, how to look at activity, really go over the stages of the change, how to prepare patients and clinicians, how to prescribe physical activity to our patients, how to have our staff collect this information in an easy and simple way, how the physician should interpret them, then prescribe, and then ultimately how to bill and create this part of our practice. So I think they're doing a great initiative, and an extension of that is a way to assess and prescribe is also the 5 A's: asking, advising, assessing, assisting, and arranging. And a way to prescribe it, aside from the standard way, is using the FIT model, being specific with the frequency, intensity, time, and type. And I'd like to go over this FIT model with how we can easily help our patients meet the requirements we currently have. So how do we make this work? How do we make this across the scale? It needs to be widespread. We need to do it. Each individual one of us need to do it, because it's not that this model, this research does not exist. It needs to be implemented. So the way we can start is we collect it at every visit by all specialists. It has to be consistent, quick, and easy. Many EMRs are doing it. Kaiser is one. There's many others who are doing it. And then we need to be able to also bill for this. Billing means incentivizing. We need more incentives as well, because unfortunately the way our healthcare model works is that with our fee-for-service model, we're incentivized for treating downstream health outcomes rather than prevention. And I think something that's worthy to increasingly explored, is value-based care. Ultimately, we also need a collaborative model to help accomplish this. So what are our goals, though? We briefly talked about it before. It's that 150 to 300 minutes of moderate to moderate intensity activity with 2 days a week of strength training. I'm going to go more into this later. And for children, it's 60 minutes a day of vigorous. So my specific proposition is that we need to track steps to meet this goal. And I'll explain how. It's it's a simple marker for physical activity. It's easy to fit in every one of our lives, and it bypasses the time requirement, a lot of the barriers needed. You can get a 10-minute walk in the morning, a 10-minute walk during lunch, a 10-minute walk in the evening, and add it wherever you can. Increasing the number of steps we're able to do is directly correlated with lower mortality. And it's easily done at our office. We can easily celebrate the success of our patients. And now I want to go back to that factoid that I mentioned at the beginning of my presentation. 110,000 deaths could be prevented each year if we could improve physical activity by 10 minutes each day. That's a small amount. You know how many steps that is? That is 1,000 steps. 10 minutes each day, 1,000 steps. That is a very achievable number. So it is one of the simplest activities you can prescribe, like walking. Walking is actually a moderate intensity activity, so that fits what we need. And if you go hiking, that's the vigorous intensive activity. And some of the other options that in there, like yoga, high intensity interval training, tennis, like walking is the easiest thing we're all aware of and we can easily prescribe. But let me tell you how to specifically do it. Let's go back to that FIT method. FIT stands for frequency, intensity, time, and type. Frequency, 5 days a week. Intensity, 4 miles per hour when they're slightly short of breath. Time, 30 minutes of walking. Type, it's a brisk walk. So on average patient, the average person walks about 2.5 to 3 miles per hour. That's around 2,000 steps per mile. And when we do the calculation, figure it out, to get to that 4 miles per hour, we're really bumping it to about 4,000 steps per 30 minutes. I did the calculations, and if you want patients to get their activity in, you do that, you get the 30 minutes of physical activity 5 days a week for 150 minutes, and you've met their physical activity requirements. And if every physician was doing this and accomplishing this, we've met the physical activity requirements of America. And if you increase that, press the pedal on that, you get weight loss, you get improvements in health, metabolic improvements. So my plan, but plants are an important part of my plan as well, is to track. I start by tracking steps for the first month. The next month, I increase it by 2,000. Just by doing that, changing that and nothing else, they see improvements in their health, weight loss, and so much more. And my goal is for the average person is 8,000. That's what I think is practically achievable for all my patients. And that may differ on, how well you can be a good behavioral counselor and how well you're achieving your goals. So what could this look like? We want something quick, easy, simple. So we want all that. So what that could look like, this is a simple vital signs page with, I added in, if you look at below oxygenation steps. Imagine if you saw this I'm admitting hospitalists primarily. If you saw this patient that you're admitting for CHF, they're only getting 2,000 or 3,000 or 4,000. You get a quick snapshot of their activity levels. And I would argue, don't you think there would be a benefit if you saw this in the ICU space? That if you could see that this patient is only getting 1,500 steps, and this is directly related to their ICU admission, I think there is some benefit there. And for us to be looking at this at all times. Steps, maybe I should have highlighted this. It's steps, I added this in, typed it in right there, right above where it's blacked out. So walking is part of this physical activity, so is hiking, and it meets that moderate intensity level. But what do we need to do this? In today's age of technology, where we all have iWatches and so much technology, all you need is a pedometer. All you need is maybe a watch too, and something to track. That's all you need. And if you know how to guide your patients, that's all you need to help them meet their physical activity levels. Now, again, me doing this in my own small little world have been developing this. But something we always need to do is we need to see what's happening in outside of our own clinic and learn from them and contribute to them. So the Surgeon General has already been talking about this. This is the Step It Up program. And they recognize that steps, walking in is integral to health. And they realize that it's easy to do. And so many patients have access to doing it. They want to highlight it, promote it, encourage it as to treat chronic disease. They want to create walkable spaces, create environments we can walk more, and educate patients and healthcare professionals to do it. They also recognize the need to collect data and research. So I hope we actually do start looking at step count in the ICU. And I do hope, Dr. Murthy sends me a thank you note for this lecture. So what else can we track though, other than steps? There are so many things we can track. One interesting phenomena is that the hours spent standing, so standing dips do help. You stand 2 hours per day, that decreases your all-cause mortality by 10%. Move that up to 8 hours, that decreases by 24%. Flexibility, body composition, waist circumference, strengths, metabolic equivalence, exertion, maximum heart rate percentile, and VO2 max. VO2 max is great. I think that's underappreciated and needs to be explored more. So I want to slow down and mention why I feel physicians are sometimes struggling with this a little bit more. And some things we're criticized for is kind of the eat less, move more approach. And technically, this is correct. This approach works. You eat less, that's less energy, less calories. More, you expend more calories. But the issue is that we unfortunately don't know how to communicate those steps very well. We want our patients to go from A to Z when our patients may not know from how to go from A to B to C to D. And that leaves them confused when we're not able to communicate effectively treatment plans. So I think there's a lot of room for us to learn about how to communicate in this field. And we have to take more ownership in this guidance if we really want to promote this as a way to heal our nation from chronic diseases. That means involvement in tracking data, talking about it, learn the language of fitness, how to speak to our patients in simple ways that they can understand, and when to refer and create a collaborative approach. So what are these languages? What is the language of fitness? It's often just being able to talk about steps, macronutrients, how that fits into their calories, basal metabolic rates, like non-exercise activity thermogenesis and associated energy expenditures, VO2 max, how that contributes, and when it comes to body composition, talking about weight loss versus fat loss. Now, for the average physician, this is still challenging because of the lack of education we get with nutrition and even activity in medical school, which I think we highlight to ourselves and we are taking strides to improve. But we all have the ability to start learning about this ourselves. And one thing that I advise all physicians to do is get a physical fitness trainer themselves or a coach. It's a great way to learn and improve our own health. There's so many resources out there. I'm not going to go into any of these in depth, but it's important that we're aware and we figure out what resources that we can use at any point in time. The future of preventative medicine. The way I see it could look like is that every time you come in to your primary care office, we set an ideal body composition goal and also set goals for obtaining your optimal level of skeletal muscle by improving your VO2 and really using exercise as medicine, where it's been shown to be almost equivalent to many medications, if not better. Food as medicine is an integral part of that as well, and that is also involved with tracking, I think parallel to exercise. And I really believe there's a huge potential to be able to partner with gyms and other healthcare professionals. So in summary, implementation, really, we often lean towards, I think sometimes we lean towards big hospital systems to lead the way in implementation, but I really want to give the power over to you as a physician and to our patients to demand this of our physicians and to see how you could simply do this for yourself if you're watching. That tracking physical activity will allow us to get our patients to their optimal health, and you can do that in your own office. And when we do that, we see other physicians doing that. We see the community doing that. We talk about it more, from 60% to 100% with each patient. And if you could start with something simple, that's steps. And how you can communicate this better and create plans, it is to educate ourselves more about how to do this. And I hope that you consider the next time you need help controlling your patient's diabetes or high blood pressure, or you as a patient need to control and get off medication, I hope you turn the knob up on the physical activity levels you're doing daily. to improve your health. So here are my sources, and I'm open to any questions that you may have. Thank you for your time.